Hi, Manju.
Hey,
Hi.
David. Hi, everybody.
Great. So thank you, everyone, for joining us. I know it's for those who attended R4P and attended a lot of the advocacy sessions. It's been 2 weeks of a really fantastic conversation, but I know everybody is Zoomed and screened out. So it's really exciting that you have all joined us. And you know, when Jessica was first imagining up this session and it was the end of 2 weeks, you know, I was a little bit concerned, are we going to get the energy? But the truth is the number of sessions during R4P that the use of new products for pregnant and breastfeeding populations came up as questions, even when there was no discussion about it in the sessions, is a real indication that this is finally reaching beyond the few advocates and researchers and implementers who are concerned about it. And this is a really critical issue that we really can get movement on. So for today's session, we are going to have a really excellent overview of the pipeline for research in HIV and HIV prevention in pregnant and breastfeeding people. We're going to discuss some of the outstanding research questions and the advocacy needs. And hopefully, we're going to generate a few key recommendations to move us forward. And I'm very happy that we have today Dr. Lisa Noguchi, who's the Director of Maternal and Newborn Health at JPIGO. She's a certified nurse midwife, infectious disease epidemiologist, and 20 years of experience in this field. She's also the co-protocol chair for the MTN 043 study, which is looking at the use or the safety of using the dapivirine ring and oral PrEP while breastfeeding. And I've learned a lot from her about this field. I'm very excited that she's here with us. Also, somebody who is very familiar to all of us, Lilian Moreko, one of our leaders in HIV prevention advocacy. As all of you know, she is the executive director of ICW East Africa. She also, among her many, many awards, won the 2019 Change Courageous Changemaker Award, and has been involved in women's health advocacy and prevention HIV advocacy for many, many years. And was also part of the Phases project that developed a call to action, a guidance for advancing responsible HIV co-infection research with pregnant women. I'm very happy that we have Dr. Daniel Were with us. Dr. Were is the director of Bridge to Scale project in Kenya, which is looking at rolling out PrEP in Kenya, evaluating and designing those studies. And as an implementer, he's also part of the rollout program for getting oral PrEP to pregnant women. Doreen Kamigisha, who is the study coordinator at Muju Research Collaboration in Uganda, who has many, many years as a community educator supporting trial communities, and is also involved in the ongoing studies in Uganda, looking at safety of using the ring and oral PrEP in pregnant and breastfeeding communities. So the way this is gonna go is first I'm gonna hand over to Lisa, who is going to do an overview presentation for us about the pipeline of research. And we're going to get to ask her a few questions. And then I'm going to hand over to Lilian, and Lilian is going to have a moderated discussion with our speakers. So this is a little more traditional than some of the advocacy sessions we're having, but I think this is the format we need to get us all on the same page first. So with that, just thank you so much, all of you, for joining us. And I am going to share screen.
Thanks, Manju. And while you're getting the screen shared, let me thank you and AVAC for inviting me. And thanks to all of you. You say you've learned things from me. I've learned so many important things from the advocacy community. So I very much appreciate being here and having this opportunity to do this exchange. So I've put here on this opening slide a variety of affiliations that I have here. As Manju mentioned, I've been working with JPIGO for about the past 6 years or so, and with the MTN for many more years longer than that. So go ahead, next slide. So as Manju mentioned, we're going to be talking about the current research pipeline for prevention during pregnancy and breastfeeding, some key areas for future research, and for engagement of advocates. Next slide. And I promised Manju I'd be very careful to stay within my 15 minutes. So if it seems like I'm going through these slides kind of quickly, even though there's a lot of text, please know that we're going to have a little time afterwards to talk through some of them. So this is a fantastic slide that AVAC created, and I've added a column here on the right side of the screen. It outlines sort of the next couple years ahead in biomedical HIV prevention research and the status of the trials that are ongoing. And on the right here, for each product and each study, I've tried to put a little bit of information about what this means in terms of the pregnancy and breastfeeding angle. And we're going to go through these products one by one, but I'll start by saying that this, as Sharon Hillier says, and I think a lot of you know her, this is kind of a short story. You know, we have some data on oral PrEP, probably the most of all these products. We're getting more data. We have some on the ring, and we're getting more actively right now, actually. And then everything else is a little bit further down the road. Things like antibodies, CAB-LA, vaccines, et cetera. Those data are coming a little bit further down the road. When you look at something, let's see, I'm going over to the right-hand side of the screen. When you look at oral PrEP here for the Discover trial and the monthly pill here, for the Discover trial, for FTAF, Lisa Rossi had just mentioned to me that there's been some recent conversations around including pregnancy data in these trials. So if women become pregnant during these trials, that there'll be an opportunity and a plan to collect data on the pregnancies that do occur, which is good news. For the Empower 22 trial, my understanding is that pregnancy and breastfeeding will be excluded, as well as in the vaccine trials mentioned below there. We do have a little bit of safety and pharmacokinetic data on the injectable CAB formulation, and I'll talk a little bit about that as we go on. Next slide. So how can we tell actually when pregnant and breastfeeding people are being excluded from studies? Should we be assuming that they are or they aren't? Well, there are actually some strategies that you can use to find out whether studies are including pregnant and breastfeeding people. This website here, clinicaltrials.gov, and there are a number of clinical trials registers or websites around the world. There are some that are specifically focused on African trials. They have a section in general called criteria or study population, where they outline the inclusion and exclusion. And many studies, not just HIV biomedical prevention studies, but many medication studies in general will list under inclusion and exclusion pregnancy and breastfeeding as something that is actively excluded. You can also check protocols that are published online for the DAIDS clinical trials. They tend to outline this information. Package inserts or medication information that comes from industry as part of a regulatory approval, these tend to have sections on pregnancy and lactation. And when we see that they say, well, there are inadequate data to say whether or not this medication causes problems in pregnancy, it's often because pregnant and breastfeeding people weren't included in trials, and so we just don't have the data. For antiretroviral drugs, there's a whole antiretroviral pregnancy registry. In general, that registry focuses on treatment drugs and drugs that have been used for prevention of perinatal transmission, but they do summarize what is known about safety in pregnancy. But I think one of the important things to know is that often inclusion of pregnant and breastfeeding people gets publicized more than exclusion. Trials don't like to crow about the fact that, oh, we didn't, include any pregnant or breastfeeding people. I think, the MTN, for example, we love to publicize when we've been able to include pregnant and breastfeeding women and get data in a safe and ethical way. So you may see inclusion more than exclusion get news. Next slide. So as I mentioned, PrEP, and I'm going to make the assumption that all of us are familiar with PrEP to some extent. This is where we have the most safety data among the biomedical interventions. We know that there's already a recommendation from the WHO in both the HIV recommendations and the antenatal care recommendations, specifically to include pregnant and breastfeeding populations. And we're hoping that the new PNC, postnatal care recommendations, which will come out at the end of 2021, will also specifically include PrEP. And some of us, including me, have done some advocacy with WHO to make sure that these get included in the postnatal care guidelines as well. We do have some sample clinical guidelines from the CHOICE project that was jointly done by JPIGO and FHI 360. And these clinical guidelines have been published in PrEP Watch, and they are linked to COP21 guidance from PEPFAR as well. What we tried to do in these clinical guidelines is point out that we had to take a very careful approach to safety, I'll have to say. There isn't a whole lot of clinical guidelines published out there from any country specifically dealing with pregnant and breastfeeding populations. But what we do know, we did outline there. There's still some gaps in evidence, of course. We have hopes to gather more complete evidence of safety of exposure in different trimesters, different stages of pregnancy for extended periods of time. And we still have many gaps in implementation research for pregnant and breastfeeding populations, specifically around demand generation, community-based delivery, uptake and continuation, acceptability, feasibility of integration into ANC and PNC services. So getting data on the best strategies for those things are going to be very important. Next slide. Depivorine vaginal ring, super excited that WHO approval is here, and we already know some important things about pregnancy and breastfeeding. We have some data already published. We know that limited exposures to the ring in early pregnancy weren't associated with safety risks. We know these from the phase 3 trials where there were a few incident pregnancies. Drug levels in breast milk of lactating women who weren't breastfeeding their infants anymore, but we were able to measure drug levels in their breast milk. We found that they were very, very, very low. It's so low that it's just not clinically plausible that the amount of depivorine would cause risk for infants, which made us feel more comfortable about actually using the ring and studying it for breastfeeding mother-infant pairs. The ring does not appear to disrupt the balance of normal bacteria in a non-pregnant woman's reproductive tract. And this is important during pregnancy because some disruptions have been associated with things like water breaking too early or preterm births. And so that it's very reassuring that the ring doesn't appear to have any adverse effect on the environment within the vagina. Next slide. So more data are coming soon. This is super exciting. We are actively enrolling in these studies, the DELIVER study and the Be Protected study that are addressing ring and PrEP use in pregnant and breastfeeding mother-infant pairs. And these studies are going to give us a lot more answers about safety, drug levels, adherence, et cetera. And we're hoping that within the next year, we'll have data from the first cohort of DELIVER, as well as final results from Be Protected. But we're still going to need a lot more implementation research for both of these products. And the WHO statement for the ring also acknowledged that data are valuable and forthcoming. Next slide, please. Okay, so what do we know about the injectable cabotegravir, the long-acting version? This product is given monthly or every 2 months, can stay in the body for a year or longer following discontinuation, possibly longer on average in women than men. When they actually looked at average drug levels in women versus men, it tends to hang out in women's bodies on average a little bit longer, but there is a fair bit of variability in that. There have been already some studies in animals that didn't show any warning signs related to pregnancy. And we have a little bit of data in human pregnancies, but more would actually be better. The few pregnancies that have been recorded that have been exposed to CAB-LA didn't show any clear safety problem for pregnancy, which is reassuring. It is the same class of drug as dolutegravir, And I know that probably most of you are familiar with the story. On May 2018, there was a possible association with neural tube defects, a type of birth defect, when dolutegravir was taken around the time of conception. But we have had more data since then, and this more recent data has shown no substantial difference in risk compared to exposure to other antiretroviral drugs. Next slide, please. So antibodies for HIV prevention. So this has been in the news absolutely this week and last week and beyond that as well. Antibodies, of course, naturally are made by our body's immune system, and they can clear infections, or they can help to clear things that cause infections like viruses, or you can make them in a laboratory, actually. BNAbs are antibodies that can neutralize many different types or genetic variants of HIV. And they actually develop naturally in some people after a while in small amounts if they've been infected with HIV for long periods of time. But in general, they develop in small amounts that aren't necessarily able to help that individual person to a great extent. So in HIV prevention studies, it has been possible to generate BNAbs in such a way that they could be given by intravenous injection or intravenous infusion or injection, and some still very interesting exploratory research about whether or not we could use antibodies for HIV prevention. And we learned, of course, in the past week or two, that people who were given infusions of monoclonal antibodies every 2 months had a 75% lower risk of getting HIV, but only if they were exposed to strains of HIV that stayed susceptible to that one particular type of antibody, which is not necessarily the big picture of all the circulating strains of HIV that are out there to which people could get exposed. So has there been any research on BNAbs in pregnancy for prevention of HIV? Well, not in the mothers themselves. So we haven't yet tested whether pregnant people can be protected from HIV by using BNAbs. That is still, I think, that we're not there yet. There has been some research, on the other hand, to look at whether or not BNAbs could be a way to contribute to PMTCT strategies. But that we're not quite there yet for that research either. So still sort of in the exploratory stages. Next slide. So vaccine trials in general have excluded pregnant and breastfeeding populations. The standard approach is that pregnant people aren't currently accepted as volunteers. This is taken from the HVTN approach. And people who plan pregnancy should postpone it until after trial participation. Pregnancy tests are done as part of the screening process and before each immunization. And women of childbearing age must agree to an adequate method of birth control prior to and during the immunization period. But we know that sometimes in trials, pregnancies occur anyway. Next slide. And what can those unintended pregnancies from HIV-1 vaccine trials tell us about safety? Belinda Stranix-Chibanda actually pulled data together from 53 different vaccine trials and tried to see if she could pull out all the different pregnancies that had occurred among the women who were in the trials, and what could we learn about those pregnancies. So data from those studies, 74% of those studies had at least one pregnancy. With an overall pregnancy rate that is shown there. And the follow-up period tended to have higher numbers of pregnancies during that period where pregnancy was no longer discouraged. So the trials had many differences. These were for different vaccines, different adjuvants, which is part of the vaccines, different geographies, but they didn't see any clear signal of increased risk for pregnancy or birth outcomes. And what they concluded was that more complete data would be needed to collect information in a systematic way in these early trials. Next slide. So sorry, lots of tiny text on this slide here. You can see that there are so many products in preclinical development, some fewer in phase 1 and fewer in phase 3, 3B. When we look at whether or not these products have actually been explored in pregnancy, for most of them, we would say, no, we don't yet have data. But this is the big picture, and very grateful to AVAC for maintaining lists like this that help us understand where we are in the pipeline. Next slide, please. So what do we need to move towards safe and ethical inclusion of pregnancy and breastfeeding for these newer products that were on that last slide, these newer products under study? I think Manju might have mentioned the PHASES project, which has been very valuable in publicizing this issue. We've had some federally funded work within the US to look at how we can approach this more systematically in different parts of the research community and regulatory community. But ultimately, researchers, industry, clinicians, funders, civil society, we're all going to need to come together to share knowledge and collaborate on a way forward and make these paths transparent, because oftentimes the paths aren't so transparent. It can be hard to find information on the approach that funders and clinicians and industry want to take in terms of inclusion of pregnant and breastfeeding populations. We're going to need lots of expertise from these areas mentioned on the slide to make sure that we're doing this in a safe and ethical way. And on the bottom of the slide there too, I have bolded a community partnership and research literacy and lived experience of these populations that we're hoping to benefit with these products. Without their voices, I don't think we're going to hit the mark. Next slide. So sorry, so much text shoved into this slide, so I'm not going to mention it all. And I want to thank Lisa Rossi for introducing me to this 3 key messages model many, many years ago. I use it all the time. And when I tried to think about messages or 3 key messages that we might want to think about as being important in this particular area, these 3 came to mind. The pregnant and breastfeeding people are a really important population for new HIV prevention methods. And all the reasons are listed there. Research on HIV prevention options is often done for pregnant and breastfeeding people too little, too late. And that's why we have situations where even in the WHO recommendations or commentary on PrEP and CAB-LA note the lack of data. So things get to the approval stage or get to a stage where we know that there are going to be good options, and we have to push that pregnancy study to the post-market phase. And lastly, we need to accelerate the safe and ethical inclusion of pregnant and breastfeeding people in this research. This research does take a lot of time and resources. And we already know that some frameworks for safe and ethical inclusion before regulatory submissions have been pioneered successfully. Multidisciplinary collaboration is possible and it's essential. And ultimately, this rationale that we hear a lot of insufficient safety data really has insufficient detail. Next slide. So here are some questions for consideration. I think as advocates think through what can they advocate for and what do we need to understand about individual products. And this gets a little bit technical here, but let's think about it. You know, if a product is going to be used potentially in safety or potentially in pregnant and breastfeeding population, what's the plan? If there's no plan, why isn't there a plan? And ultimately, we want to have adequate choices for everyone who's at risk for HIV. And we want them to be able to understand the risk-benefit profile of products, including the impact on pregnancy and breastfeeding. Those preclinical safety studies, they're also called reprotox studies or DART studies in animals. These often need to be completed before studies in pregnancy and breastfeeding can occur. So are they completed? If not, why and when? When in the timeline, as I mentioned, will people be included? For trials that actively exclude pregnancy and breastfeeding, will data be collected on key outcomes when unplanned exposures occur, like the Gilead trial that was mentioned earlier? And for approved products with inadequate pregnancy and breastfeeding, why was this approach taken? We actually need to understand the who, the how, the why of these missed opportunities, and we need to hold our field accountable. And what do we need to learn about optimizing rollout and delivery? We have to realize that the journey doesn't end with an approved product. An effective product or an efficacious product for a trial that doesn't end up getting used really is a sad missed opportunity. Next slide. So I'm going to close there and turn it back over to Manju and our moderators. Thank you.
This is Lisa Rossi. Can I just jump in and just clarify something? Because Lisa and I were in communication last night, but she was under the weather a little bit. But the discussion, as some of you know, about with Gilead is for the Empower 22 study that they would be collecting the pregnancy data. Yeah, I just wanted to clarify that because.
Thanks, Lisa.
Sure.
It was news to a lot of people this week, so thank you for reminding that. So first of all, the other Lisa, thank you so much for this. This is a really amazing slide set, and I think we could spend a lot of time like really mining it, and already had some requests for your slides, so I hope that's okay with you. Before I hand over to Lillian for a discussion about doing exactly what you said, how do we call the field to account? How do we move forward really strategically in all these areas? I want to open it up for any questions on your slides, on the research that you presented, on any clarifying factors on that. There are a few comments in the chat. Bridget is asking about MPTs. Do you want to say anything about MPTs, Lisa?
Sure, and I think this is an area that has been of great interest to the MPT community to try to figure out individual components of MPTs that would be safe during breastfeeding, particularly for the breastfeeding infant, and a way to use, for example, an ARV that would not cause adverse effects, but also a contraceptive that wouldn't affect the quantity of breast milk or change that. And so one of the current formulations of Ring actually does that, includes a particular hormone for contraception that does not adversely affect the quantity of breast milk. So I think I totally 100% agree, and thankfully some research is already underway.
Great. And Lisa, I wonder if you can see there's also a question from Supercharger in the chat.
So is it helpful to collect all the global data of ASEs of women getting pregnant while in studies so as to find out whether women need inclusion? And I need some help on the acronym there.
Supercharger, do you mean adverse events when you say ASEs?
Yes, dear Manju.
Thank you, dear Moses.
Ah, okay. Yes. So, and it really needs to happen. So I feel like it's happening sometimes systematically and sometimes not so systematically. So yes, the idea is that it would be really helpful to collect this information across trials and then put it together in a very systematic and scientific way. So to make sure that the conclusions that we draw are valid. So yes, I agree with you. There have been some efforts to do that, to do this kind of review of data that pulls different studies together, called a systematic review, and actually tries to sort through the quality of the data and tries to sort through the different side effects associated with different products. But I think it's an area that is could be better funded and could be more complete than it is right now.
Thanks, Lisa. And I'm actually going to, I think that any other questions that come up, we can really take it in the moderation area. So I am going to hand over to Lillian now. But before that, Brianne, is there a poll question you want to give the group?
Yeah, we could run a poll for the group just to get a sense of where folks are at with some of this. All right, we actually have a couple of questions. So the first question you'll see on your screen, the current default around the involvement of pregnant and breastfeeding women in research is, and this is anonymous, just want to see where folks are at, what you're thinking. Seeing some votes come in. Oh, we seem a little split on this. I'll give a couple more minutes. A few more folks. All right. And it looks like most people think that exclusion is the default, but others, also believe that inclusion is the default. So perhaps, we could weave that into the conversation if one of the facilitators wanted to touch on that. And let's see. I thought we had another question, but now it's not popping up for me. Oh, here we go. Okay. So the next question, ongoing studies are assessing the safety and efficacy of PrEP and the dapivirine vaginal ring in pregnant and breastfeeding women. So what does everyone think on this one? Give folks another couple of seconds. All right. And it seems like we're a little split on this one as well.
So this was a bit of a trick question.
I was wondering that.
Yes, it was a bit of a trick question. Lisa, do you want to, Lisa Noguchi, do you want to clarify for everyone?
And I want to say that I'm not responsible for this trick question. Safety, yes, absolutely safety. Drug levels, yes. Acceptability, yes. Efficacy, no. We have the efficacy data from the phase 3 studies, and we haven't designed studies deliver and be protected to assess efficacy, whether or not there's prevention of HIV infection in these particular studies.
Thanks, Lisa.
Thanks so much for that clarification, and apologies everyone for the trick question. And we have one more quick question before we jump to our discussion. So this last one, the biggest obstacles to including pregnant and breastfeeding women in research are ethical, scientific, regulatory, or maybe something else. And there's no right answer, of course, but just curious where folks feel like the biggest hurdles are. And we'll give just a few more moments for those final votes to come in. All right, let's share results. So many people think ethical reasons are ethical considerations are big challenges. A lot of people said others, so I'm curious to hear what those other elements might be, but also a few on regulatory and scientific. So I think it just shows there are lots of factors that go into this.
Thanks so much, Brianne. And I'm sure that is great fodder for Lillian for the next section. So Lillian, I know we've cut into your time some, but I am handing over to you with thanks.
Thank you very much, everybody, for turning up for this important session, but also Lisa for setting the stage for us. And I think this last question opens up to getting into the conversation with our 3 panelists. We hope that they should be able to help us understand, especially the last component in relation to the biggest obstacles. So Lisa, I'll have to start with you as a follow-up to check in with you before I get to Daniel and Doreen. I wanted to hear more and understand from you what you see as the most difficult, what has been the most difficult in terms of getting support for trials involving pregnant and breastfeeding women, and especially looking at the last question that we've just had, where people have varied views.
Earlier, I had a talk with China CDC director, Disease Control Center director. He told me that he congratulated these.
Lisa, did you hear me?
Yes, I did. Sorry, I just was, thank you for the muting there. You know, I'll be honest, I think one of our biggest barriers is kind of an old gender bias here. We have a very protectionist attitude over women's bodies, one that doesn't encourage women to make their own informed choices here. And the desire to take away that choice of whether or not to participate in a trial, I think is has a lot to do with that. I think it also has to do with the fact that if we valued women's lives more in the world, I think there would be more investment here. There would be more interest. There would be more time. But the lack of value on women's lives, I think, has been a problem.
Thank you. Thank you. You're just reminding me of the few things that have just happened in the past that we had a lot of engagement around the DTG and choice, and indeed was an issue. But we also looked at the use of hormonal contraceptives and particularly DMPA. So I think you're speaking to the things that are still clear in our minds. But thank you so much. Daniel, thank you very much for the work that you're doing in Kenya. We really are grateful to learn about it, but also to follow you. And our communities are really appreciative. I just wanted to check in with you in terms of the point that we are discussing right now. We know that you have done a lot of work and you're supporting the rollout of PrEP, especially to the population that we are talking about right now. Is it possible that you can share with us what you see as the community response and some of the challenges that you are facing as you roll out this PrEP and in the population that we are talking about?
Yeah, so thanks, Lillian, and hope you can get me clearly. Certainly as far as the rollout of PrEP is concerned, I think from a community perspective, I would say that it has been much easier to roll out PrEP, particularly for pregnant and breastfeeding women, as well as, of course, populations like serodiscordant couples. It has been much difficult when we go to other populations like key populations and adolescent girls and young women. But certainly, I think the challenges around delivery of PrEP for this population are more or less from the delivery dimension. And of course, while in Kenya, the beauty is that we have had an accommodative policy environment that right from the onset of the scale-up, pregnant and breastfeeding women were included. I wouldn't say the same of quite a series of countries in sub-Saharan Africa, where we've seen a lot of bureaucratic red tape around scale-up, and of course, quite a number of these concerns stemming from concerns around safety. But nonetheless, as you look at it and if you review the existing evidence, for me, I think it would make more sense to increase access than probably invest more in ongoing surveillance around safety during routine implementation. But also the other point I just want to talk about delivery is how are our delivery systems set up, and do they permit improved access, particularly for pregnant and breastfeeding women? Because if you look at how the delivery of PrEP is set up, if I look at the example in Kenya, and probably the same could be replicated in a number of countries, is that the primary delivery point is basically through comprehensive care centers or the HIV clinics, basically where which is a more ideal delivery platform, particularly for serodiscordant couples. But we see, of course, you'll have women who are not necessarily in serodiscordant relationships who have difficulties or discomforts accessing services from such points.
Uh-oh.
I think we've lost you. So I think let's move on to, okay. Daniel?
Yes, sorry, I hope you got my points.
Yeah, I think we missed you at some point, but we can come back to you on that. But thank you very much. I think you're raising very, very important points, and it adds to where we are coming from. But I think you are also mentioning strongly the issue of accommodative policy. And you gladly mentioned that pregnant women are receptive. And therefore, I think the conversation moving forward, we'll have to look at safety vis-a-vis choice, options, and putting women into the conversation. But we shall come back to that shortly. So Doreen, thank you very much for the great work that you do as you support and work with on trials. Would like to hear from you, especially around the work that you're doing in Uganda, what so far you have focused on in terms of community engagement, what efforts you have put in place, and how supportive are communities in trials, and what would be your recommendation moving forward, especially how can we make sure that we are supportive and communities are engaging and engaged, and especially this point in time, a community of pregnant women. Over to you.
Oh, thank you, Lillian, and hi to you all. I'm really delighted to be a part of this panel, and I'm glad that Manju and Lisa, you too, Lillian, you're part of this, because what I will share basically was a joint effort with all the members that I've mentioned, and right from the beginning, we really thought that conducting research in pregnant and breastfeeding women would really be quite challenging, because it's what the scientific world had really painted. But we are glad that once we laid our strategies well, we were able to break through what we thought was hardcore. And how did we do this? Of course, as you all know, I believe majority on this platform are advocates for HIV prevention, and we all know that pregnant and breastfeeding women are at high risk, but we know that some policies and guidelines would not include them, just like other clinical trials we've already conducted. But what we thought through was to engage the key stakeholders. And who are these? We looked at the policymakers, civil society organizations, service providers, religious leaders, cultural leaders, midwives, private midwives, and had their views. And remember, this is systematic. You have to dig deep and tap into the people who are really resourceful in this whole agenda. Who are these people who understand the pregnant woman? Who are these people who understand a breastfeeding woman? Who are these people who are willing to come forward and speak their voices towards these populations? So we are glad that we are able to conduct stakeholder engagements, and there were quite a number. And I will mainly talk about the in-country, because they were prior stakeholder meetings that were regional, but the in-country really informed us and gave us support. Actually, I must say that we got support from a well-organized key stakeholder meeting that we had in Uganda. And people really showed us that they were behind us to have these studies move on, to have pregnant women and breastfeeding women brought on board. And of course, they also mentioned to us that as we had engaged them, we also needed to engage the broader community. And who are these broader community? The people in which we are going to tap, the people from the communities from where we were able to recruit these participants. And also we had representatives from such communities who are able to give valuable input of how best to get these ladies on board, how best they needed their support. And to you, I must mention that key points that stood out during these engagements are that really with pregnant and breastfeeding women, they are vulnerable. Everyone acknowledges the vulnerability. And male support is really critical. That was the main point that came out, engaging male partners. And I must say that we had male partners also in the stakeholder meeting that had participated in a prior informative study of MTN 041, which was looking at acceptability. And they really gave us their thoughts, and we had to write by their thoughts, engage the women. Remember, as we engage communities out, our recruitment is narrowed to the ANC clinics and PNC clinics. But then again, there are some men who come to these clinics, and how best would we engage them, have time with them, explain to them, because we've had many challenges where male partners would not accept their women to participate in these trials. But once they engaged and given information, some of them actually approve of trial participation by their partners and are willing to support them. So what key points do I bring here? That meaningful engagement of communities and key stakeholders offers us different views and perspectives during the preparation and also the implementation of these studies. Once we have this done systematically, sourcing for the actual people that will give us the information that we need, then we would be on the right track to have these studies conducted. And I must say that they are moving on very well. Something we once thought that would be very hard, it has been very easy for us, that actually even women acknowledge their need to participate in these studies, because they have come to an extent of accepting that either they are at risk or they really need these products because they know their partners put them at risk of HIV. Yeah.
Thank you very much. In a minute or second, can you really tell us of those stakeholders that you engaged? Were there groups that were hard really to convince, so that as we move into our next steps, we know how to engage better with different categories of people?
Actually, I must say that a particular group, it was religious bit, and right as we're setting foot out to approach them because of the known norms in their religions, we knew that that was expected. But we are glad that they came forth, they acknowledged, and I think with constant education and information sharing with these categories of people, we will have them on board. What we realized is that the fact that they lack information, that's why they stick to their initial norms, and at times find it hard to embrace the current situation or move along with the current situation. But really, I will say we would not have a big challenge. What we thought would be a challenge actually was not. Yeah.
Thank you very much. I think what Doreen is bringing to us is that if we meaningfully engage and bring everybody on board, chances are that we are going to have a group of people who understand and believe, and we can really push. And I think one of the stakeholders that we may have to start thinking about as we advocate and move forward is how do we make sure that the ethics boards understanding some of the conversations that we are having beyond the ethics, but that there are other things that should be included and seen from their perspective. And I think one other key point that Doreen, you're raising is that sometimes we sit in our comfort zones and we think everybody understands it the way we understand it. So we need to really share information and knowledge across so that everybody understands it from the perspective that we are. I'm mindful that my time is running short, but I just wanted to check in with you, Lisa, because this is very, very critical that, for example, we are all now dealing and struggling with COVID-19, but we also understand that pregnant women were excluded. So what does this mean, and how does this help us to advocate, to push, because it means that pregnant women probably cannot even use the products, the vaccines that are coming up. So how do we probably use such opportunities that are population affecting generally everybody to make sure that nobody gets left behind?
Oh, Lillian, such a great question. And I have to say that the conversations are going on literally day by day about this, something new and exciting on this. So I think we've seen in the past year, this just incredible acceleration of research. My understanding is that the COVID vaccine trials went from, 0 to FDA, approval for INDs and like IRB submissions so quickly. So, were pregnant women included in those original trials? No, absolutely not. But what we do have is actively gathering safety data now. We have over 15,000 pregnant people already exposed to COVID vaccines in the US, volunteers who are health workers who wanted to be vaccinated. So slightly more for the Pfizer vaccine than the Moderna vaccine, but we're actively already gathering safety data. And the WHO has just made several statements saying that pregnant people can choose to be vaccinated, especially if they're at high risk of exposure to COVID-19 infection. So this is supposed to be now an individual conversation about risks and benefits between the pregnant person or breastfeeding person and their provider. So WHO right now is not specifically excluding pregnant people, and I'm happy to share some of those resources and WHO statements with AVAC so that they can be circulated to this group here or elsewhere. But I think we're seeing some exciting news there. Now, that being said, individual countries, even though the new WHO recommendation is out, individual countries have already said, nope, we're not going to be using this vaccine in pregnancy. And that is their prerogative. But I think the hope is that everyone looks to the emerging evidence and uses that evidence in a way that informs decisions, because we know that the risks of COVID-19 infection are higher for women when they're pregnant compared to when they're not pregnant. They're more likely potentially to have to be in an intensive care unit and receive ventilator support to survive.
Thank you very much. And thank you everybody who is participating meaningfully in the chat room, and for those who are responding to the questions, thank you so much, because we can't have a lot of time to hear everybody and every voice, but the conversation is great and we appreciate. And Daniel, as we come to almost the end of our conversation, what would be your recommendation? How would you want us to advocate? How can we bring many more people to join us as advocates? And also, this is in relation to the point that Supercharger is asking in the chat room, safety for children, and the point that Lisa raised, voice, choice for women. So we have two competing issues here. What should we be doing moving forward?
Yes, so thanks. So I think, the first point, I did highlight it much earlier, that really where there is already a little bit of evidence that should be sufficient enough for countries to make decisions, I think it's important for countries to move ahead and really roll out most of these prevention products for pregnant, especially for pregnant and breastfeeding women, but invest more in surveillance systems. Because I feel what we're doing is through policy barriers, essentially we are denying access to HIV prevention products in the name of safety. So for me, I really feel that that is the first point where we really invest a lot of advocacy voices. And the second thing are declarations to make it easier and convenient, basically for pregnant and breastfeeding women to access most of these HIV prevention products. I think, as I did say, the challenge with a lot of implementation of prevention interventions is actually they're being layered within a treatment-oriented system that may not be very friendly to users, but is more friendlier to the health system. So a lot of advocacy really to refine the pathways to be less inconveniencing and basically more accessible and friendlier to the users.
Thank you so much. Doreen, any recommendation as we come towards the end of this session?
The main recommendation, just like I had earlier mentioned about meaningful engagement, I would also want to add advocacy right from inception of any protocol. Because I think in Uganda, we've struggled a lot with a lot of effort in clinical trials, which have come through, have materialized, but unfortunately, we are the last to implement. And I think because I think right way back, we've not been engaging advocates right from the beginning. But it has been such a great lesson. And I'm glad that with these pregnant and breastfeeding studies, at least we saw that in light and also disseminating results, because all these contribute to the way a prospective or what do I say, a product that's going to be brought on market, how it will be received. So really advocating from the word go through to the end is very important, and also continuous engagement of stakeholders as the studies go on are also critical, especially for these vulnerable populations, to inform subsequent studies and possible rollout of products.
Thank you very much. Lisa, your last recommendation?
My best recommendation? Just for advocates in general? Sorry, I'm trying to answer questions in the chat at the same time. I apologize.
How do we take this forward? What could be the pieces that would help us get there to make sure that everybody gets engaged, gets involved, but that we are not leaving anybody behind, especially when it comes to research, we're knowing that when the products come out, then we start asking ourselves, such groups, especially that were not involved and engaged, then it becomes another issue, and then we go back and forth.
Yeah, I think we need to have conversations exactly like this. And I think we actually need to be recruiters among our fellow advocates, our fellow scientists, with ethicists, anybody who's working in this area in HIV prevention. Pregnant and breastfeeding people have a right to be included. They need safe and acceptable and effective options. And I think all of us need to be recruiters in terms of bringing people to this cause. The more people hear about safe and ethical inclusion, I think the more converts that we have for this movement. So I would encourage even more publicity, more messaging in your own advocacy, more conversations together with scientists, and more demand for accountability.
Thank you so much. One of my good advocates told me that when it is an advocacy issue, it should be oral issue. And I think as advocates, this is where we need to be getting, because issues of pregnant women should be our issues. But I think importantly, we need to bring pregnant women on board. They have to tell us. We need to listen to them, because for us, nothing for us without us does not make sense. And therefore, pregnant women should be the ones to tell us whether they care about their children. And we had it in Uganda. Women told us that there's nobody who cares about my child than I do. And when they said that, the Ministry of Health listened. So I think we need to hear them in terms of their choices, their voices, but also to tell us how they would want to see it. But Manju and Tim, can I hand over back to you? Sorry, we spent a little 5 minutes over, but please take it back.
Thank you so much. And I have a feeling that we could go for long after if we hadn't, we don't want to be respectful of people's time, but really grateful to all of you. Thank you so much, Lillian, for running such a fantastic discussion. Lisa, really great slides and a lot of interest. As you can see, you can understand we'll be calling on you for doing these kinds of discussions again. Daniel, thank you so much for always reminding us of the practical issues of actually getting this into people's hands and how to be really specific with that. And Doreen, thank you for the incredible work you do with communities and really bringing everyone on board and making sure their voices are being heard as these trials are running. So thank you so much, everyone. And thank you to all my comrades for their work. Stay tuned. We will definitely continue.